Welcome to Whiteboard Medicine. So, you may be a medical student, or maybe a nurse, or a practicing doctor, but you might have heard about iron deficiency anemia. The first thing we should know, what is anemia? Anemia is nothing but a condition in which the blood doesn't have enough healthy red blood cells, or RBC. This results in a lack of red blood cell. This leads to reduced oxygen flow to the body's organs, or dysfunctional red blood cells in the body. Talking about iron deficiency anemia, it's a major leading anemia in the world, with the 50% prevalence of total global anemia. In order to understand iron deficiency, it is important to understand which foods you should pay the most attention. The two forms of dietary iron are heme iron and non-heme iron. The heme iron is in ferrous form, Fe2+, and the non-heme iron is in ferric form, Fe3+. Fe2+ chelates into a complex organic compound to complete the heme structure, which occurs in hemoglobin and certain enzymes. It is the form of iron that is most readily absorbed by your body. You can absorb up to 30% of the heme iron that you consume. Is found only in animal flesh, like meat, poultry, and seafood. Diving into non-heme iron, which is also important to discuss. Non-heme iron is in Fe3+ form. It's harder for your body to digest. Hence body needs vitamins like A and C. Non-heme iron is found in plant foods, nuts, seeds, legumes, and leafy green vegetables. The normal Western diet have adequate iron. A young adult normal men have 6 gram iron store in body. Hence, the daily iron requirement for men is 7 to 10 milligrams. Despite of this much intake, body can only absorb 10 to 15%. So to maintain the normal iron balance, 1 milligram iron must be absorbed from diet. A healthy women with normal metabolic activity have a normal iron store of 2.5 gram, and the daily iron requirement for them is 7 to 20 milligrams. But why they have high requirement? The reason is that they have major iron loss from menstrual cycle, so they are at the constant marginal risk. Regulation of the iron absorption is done from duodenal part of small intestine. Non-heme iron is not absorbed. Hence, the problem arises in duodenal part. This leads to revert back of Fe3+, but the heme iron gets easily absorbed by heme transporter. Hence, 30% of digested heme gets in body without any extra effort. But this problem is dealt with the new set of cytochrome enzyme. It converts Fe3+ to Fe2+ for readily absorption. Now, body has heme iron, which is obtained from fleshy food, and body reduces Fe3+ with the help of duodenal cytochrome B to an absorbable form, Fe2+. Now, both iron, which is basically in Fe2+ form, enters the duodenal epithelial cell. This gets stored in ferritin, which is used by body in depleted condition. Now, Fe2+, which is present in enterocyte, needs to get converted in Fe3+ form, and this is done by a protein molecule named hephistin, present on the basolateral side, and the transporter, which is used to send Fe2+ outside the enterocyte, is done by ferroportin, because in blood there is presence of plasma transferritin, which only transport Fe3+ iron. Fe2+ outside the enterocyte is done by ferroportin, and hence body tightly control and monitor that how much iron should be in the blood plasma. This is done by a new set of molecule, hepcidin. This is the color image of duodenal epithelial, which will help you to understand the concept more easily. The iron enters from apical part and goes into the blood from basolateral part. First there is a heme transporter, which transport Fe2+ from food. This Fe2+ enters into the cell and stored as mucosal ferritin. But nearly 85% of heme goes into blood from ferroportin. Oxidized heme is transported by plasma transferrin. The major etiology of iron deficiency anemia are dietary lack of iron, impaired absorption due to chronic disease, an increased requirement due to high metabolic activity of the body, and chronic blood loss. It's the major cause of iron loss in Western countries. Dietary lack is rare in developed countries because 2/3 of heme iron is provided by meat. Situation is different in developing countries where most of iron in the diet is found in plants. Impaired absorption leads to sprue, flattening of villi in intestine. Another disorder is steatorrhea, fat malabsorption, and chronic diarrhea due to sprue-like condition. Gastrectomy impairs iron absorption by decreasing the acidity of the proximal duodenum. Increased requirement is important cause of iron deficiency, particularly in pregnant women and growing infants. Chronic blood loss is most common cause of iron deficiency in Western world. It's due to trauma. Gastrointestinal bleeding is the second most cause. Urinary and genital tract leads to internal hemorrhage. This cause depletion of iron reserve from the body. Pathogenesis of iron deficiency is its deficiency leads to change in the shape of RBC, as iron is the main component of hemoglobin, and hence it is also called hypochromic microcytic anemia. This is the pathological slide, which show light central pallor. Due to this feature it is called hypochromic, and the size is smaller than normal RBC, so called microcytic. In the early stage of disease, bone marrow activity increases because body gets confused. This leads to increase activity of erythroid precursors, and the number of reticulocytes increases rapidly. This causes increase in the peripheral red blood cells, and their number is constantly high in blood sample. As RBC number increases, body starts using its ferritin, which was stored for this type of conditions. Macrophage also contribute by giving hemosiderin. In initial time, they're very useful, but later, their number decreases significantly. Progressive depletion of these first lowers the serum iron and transferrin saturation and lead to chronic form of anemia, which is also called iron deficiency anemia. Moving our discussion to diagnosis. The diagnosis of iron deficiency anemia ultimately rests on laboratory studies. The hemoglobin level is affected due to hypochromic microcytic RBC. This leads to affecting the hematocrit. Their both levels are reduced moderately, and the total plasma iron binding capacity is high, and this reflects the elevated level of transferrin in peripheral blood. Low serum iron level, an elevated iron binding capacity, or transferrin, helps in making a diagnosis of iron deficiency anemia. The patient may present with a symptom of koilonychia, means spooning of nail bed. There is little evidence that an iron deficiency can cause alopecia, but it is also a symptom presented by patient. Patient may present with pica, unusual eating of chalk and earthy materials. The treatment of the patient includes oral iron supplementation. If he is not in complicated state, in just 5 to 7 days patient shows significant improvement. This leads to reticulocytosis, and reticulocytes number increases dramatically. This is followed by a steady increase in normal blood cells like RBC, and patient gets treated. So if you have watched our video till now, please like and share the video with your friend or family members. If you have any queries, or you would like to suggest something, please comment down below. We would be very happy to hear that. Please don't forget to subscribe our channel and press the bell icon to get the latest notification of the video. Your support means a lot. Best regards from Team Whiteboard Medicine.